Thank you very much. That was just very, very important and inspiring. Thank you so much. But you have left us with a challenge, haven't you? And that challenge is that what we need to do is now continue that dialogue that Cece really laid out, has occurred over a number of decades, and look at the challenges that we've began to surface during this conversation today. What I want to do is make sure that I begin to have members of the roundtable here focus on this relationship between public health and health literacy, and come to the microphone and begin to make your comments. So if we could make sure that people are beginning to line up, it'll cause this to move along. We'll get all the comments and reflections and observations in order. I'd certainly like every member of the roundtable to make sure that we've got 2 microphones, so we don't have to overweight on the right-hand side of the room as we look here. We can distribute ourselves equally across the room. So go ahead, Remo, get us started.
We're allowed 1 observation, is that correct? Okay, this is my takeaway observation. We have amongst us, and certainly in this room and on all of the panels, incredibly insightful strategic thinkers. So my feeling is, and my sense is as a takeaway, I want to look more closely at the case studies and at the presentations that were offered here, and I want to deconstruct them. I want to begin to ask the questions, why did you do X first and not Y? How did you do A, B, and C? I really want to begin to uncover the strategy that was underlying some of the very fine presentations. And I think once we do that, from the experts that were here in that room, we'll have a very good path ahead of us and guidance for taking action.
Thanks, Rima. Wilma?
Geez Louise, what do you say? I mean, it's just, and I don't think I've been at a meeting where my emotions have been all over the place, and in a good way, I agree with what Rima has said. I think there's a lot of information, a lot of just amazing information that we've been provided with today, and to have the opportunity to absorb and then take it apart a little bit, just to look at some of the pieces that have been presented to us. Some of what I've been listening to today resonates with me when I wear my hat as a spoken language interpreter. You know, I'll go into a room with a provider and I'll do my role as interpreter, and, you know, I will abide by my code of ethics and my standards of practice. And then we'll walk out of the room and the provider will turn to me and say, "Do you think they understood everything?" And my response is, "Well, if you're asking me, we should go back in." You know, so I say that because I do think that it would be fabulous, as what Rima has just suggested, to think about what's been going on and what are going to be the next steps and what can we do to put a plan in place to serve those who really count on the work that is being done here.
Thank you. Patrick?
From the onset of the planning of this workshop, I was really worried that health literacy would not be adequately demonstrated in the public health sector, but as a result of the work of Andrew and of the presentations today, I'm glad to report that, in fact, it is. It's just kind of a different iteration. Of course, there is all sorts of work that needs to be done, and I think really, public health department communications divisions need to make health literacy a #1 priority in communicating any health messaging, both at the public level and at the clinical level. ASTHO, current project on integrating primary care and public health, offers a great opportunity for the medical and public health communities to work together to achieve this common goal. And then, as many health departments, local health departments provide clinical preventive services and well child visits, I would love to see the Reach Out and Read program expand substantially. I think it was demonstrated in Arkansas to nationwide. Thank you.
Thank you. Okay.
Hi. So it will take a long time to, it's Terry Parnell. It's going to take a while to digest it all. I agree with everybody's comments. I think 3 words kind of come to my mind. It's continuing our partnerships and continuing to work away on finding common threads, so to speak, that we could weave throughout everything that we do. Continuing to be innovative and look a little bit outside the box, because I think that's what it will take now moving forward, and agility. So we need to take some of the best practices and the evidence and, again, in an innovative approach, really be agile to implement that. And, to what Wilma's comment about languages, I think really bringing cultural humility and language and communication access services, pull that through the great health literacy work that's being done.
Thanks, Terry.
Liz Fowler, thank you for the opportunity to be here, and thanks to the speakers for a really rich and diverse set of presentations and an excellent discussion around those presentations. I am a newcomer to the roundtable, but was left with a lot of hope that there's a chance to make progress. If you can make progress so substantially in a state like Arkansas with so few resources, if you can be sensitive enough to understand that you need to go into the communities like in Appalachia and understand the patients that you're trying to work with and the populations you're trying to work with. And also I was really moved by, of course, as we all were, the poets and the opportunity to do things differently. It seemed clear to me, based on a number of comments, that the definition of health literacy needs to be updated, and it sounds like this is the group that's going to think about that. And hopefully that updating process will take into consideration sort of the complex world that we live in and the number of ways that there are to communicate with different populations, because I think that's necessary. The other, and I know we were supposed to make one observation, but I did want to just add, a few people have mentioned the Affordable Care Act and the opportunities presented in the ACA. I think there are more than people realize. In addition to the ACOs and the patient-centered medical homes, there's also the value-based purchasing for hospitals. 30% of the bonus payments are going to be based on patient satisfaction. And how are we measuring patient satisfaction? There's new penalties for hospitals that have higher rates of readmissions. Readmissions are caused by patients not following directions and not taking their medication. So I think there's a lot of opportunity there that maybe are rich for exploring. In addition, I'm not sure how much this group weighed in on some of the provisions regarding the plain language requirement that is requiring health plans to describe health benefits in the same way and using the same definitions and making sure that patients can understand their options. And also and I think this is still yet to be implemented, the coverage examples, coming up with 3 specific disease states and exactly how much a patient will have to pay out of pocket for each of those 3 diseases. And the plans are supposed to come up with a way to describe that in a standard way so patients can understand them. So I just wanted to point out that there are a number of opportunities for this group to have a real substantial influence. So thank you for letting me be a part of it today.
Thanks, Liz.
And I'm Lindsay Robinson. I'm the dentist on the panel, and I also, I always have to say that. And I truly appreciate the opportunity to be here and provide the oral health voice within the work that the Roundtable does. And it was great to have Alice here and realize that there are so many similarities. I mean, essentially, dental disease is a chronic disease, and we need to learn how to manage it as a chronic disease. And so there are a lot of opportunities to work with our colleagues and other disciplines in order to do so. It's really hard to encapsulate this entire day into one key message, but that's why punctuation can often be your friend, commas, semicolons, on and on. But just in terms of what I thought was really cross-cutting across all the panels, that on a community level and a systems level, there's a need to have champions who can shepherd the cause and provide leadership in their particular sphere of influence. I was at a prevention summit that was hosted by the American Dental Association a couple of days ago, and there was a gentleman, Dr. Huggy Rao, who's a social scientist at Stanford, and he talked about, in order to initiate a successful social campaign, you need to initiate an air war and a ground war. The air war prepares the way for the ground war to be successful. And the air war would be like policies and systems that are in alignment to promote best practices in health literacy. The ground floor, and we saw some examples today about that, ground floor community activities like, in the Bay Area with the poets, and just what a fabulous experience to have that emotional content pulling us in and making us, it really makes us want to hear that message. It makes the message very sticky. The examples in Louisiana and Nebraska and Arkansas as well. And as a corollary to this is my punctuation point mark here. Something Rima said early today was really kind of my lens for the remainder of the day. And she said, you can't wait for the educational sector to inform the public. People are dying. This sounds like a call to action to me. And public health departments should play a major role in this, but they're not equipped right now. But I think everything we can do to make sure they're equipped to play their role, that is their ethical and legal responsibility, as we saw on the screen earlier, will be a great contribution that we can make.
Thank you, Lindsay.
I'm Lori Hall. This is an observation I made early in the day, specific to we were talking about informed consents. But I'm realizing now as I take a step back that there's really kind of a golden thread that weaves through many of the discussion points we've heard today, and that is the idea of what gets measured gets managed. And that's something I go back to often. The issue of around informed consents is that initially and in their truest sense, they're designed to protect the organization from lawsuit, right? But what if they were designed and measured in a way that protected the patient and consented the patient in a very different way? So maybe it's time that we are all very warm, compassionate people who very much believe in this cause, but maybe it's time that we take a hard look at the warm, compassionate approach alone is not enough anymore. Maybe it's for us to be able to drive change, we have to be more forward-leaning, more on the offensive versus on sort of on the more subtle approach. Maybe we need to start measuring, putting metrics behind what we do to drive the change that we all know is so important. And I'm learning that in my own organization as a pharmaceutical organization. Oftentimes change doesn't happen until there's a metric assigned to it. And then once the metric is in place, people start to buy in because they understand the value and its importance. But left alone to their own measure, it doesn't happen naturally. In this world of competing priorities, in this world of information overload, it's all too often perceived as yet another work stream, where if it's integrated and metrics are assigned to it, I think we'll start to see results.
Thank you.
Rob Logan. It strikes me that we covered a lot of bases today that were important to cover. And that I'm glad we had the kind of discussion we had. It turned out to be memorable, because there were a lot of issues that popped up today that perhaps, well, I'm very glad we explored them. Maybe that's the way to describe it. What stood out for me today was there was a principle espoused in the very first talk by Rima Rudd, the principle of the importance of community and civic engagement in all the work that we do. And this afternoon, Linda Newhouser gave a wonderful operationalization of that and the 7 steps that you take in order to do a health communication intervention. To me, I think that's the kind of thing the IOM is for. You set a conceptual floor, then you also try to provide some very concrete operationalizations and examples that people can use. So I thought today that was especially memorable.
Thanks a lot, Rob.
Kim Parson. So the words that I'm taking away from our session today are communication, partnership, and innovation. And I'll go back to one of the things that Rima first said early this morning about the importance of a communication strategy. And then as we went through the day, we saw the importance of new technology and new voices and co-creation in terms of developing what that communication strategy should be, and so who it should be by and who it should be for. And I would encourage that to drive change, we really need to make sure that we're doing all of those things to create the communication strategy for all different peoples, and that communication and education needs to begin, in preschool all the way through, not just when we have people who start attending colleges and universities of public health.
Great, thank you.
Hi, Patrick Waite, Roundtable member representing the American Heart Association. So I would add my praise as well to the speakers as well as the planners. This was a fascinating workshop. I had a variety of takeaways. I think I was particularly pleased to hear Alice talk about in oral health literacy, this issue of triggers and habits. We've been spending an extraordinary amount of time thinking about heart disease and stroke, and how you can interject at these teachable moments, these simple triggers that can create new habits with a really valuable way to change people's perception and how they live their lives. Dean's work and the group that they're doing was just incredible. We see this intersection, our organization as well, and social media campaigns, mHealth, health technology, and art coming together in a variety of different campaigns. This is great work, and how that kind of effort can intersect with what the state health plans are doing, and how those things can complement each other without making them uncool in some way, would be very interesting to think more about. And this is something the AHA does very well. We've done this very effectively in a variety of different social campaigns, particularly in women's health, and there's more that can be talked about there. And overall, again, this was just really remarkable, and thanks again. It was good to be a part of this.
Thank you. Steve?
Yes, thank you. And in line with CC's concept, Steve Rush, Roundtable member, in line with CC's statement of used pictures, I have a picture right here that Linda presented of a guy with a megaphone standing in front of a person basically standing still. And the statement was, we have messages to get out. And coming from a health insurance company, there's a ton of messages to get out. And what this session meant for me today was that we need to be very mindful of how we put messages out and how we get the consumer involved in understanding and crafting the message so that there is that remembrance. It's not what they read, but what they remember. The work of Andrew and his group set a great stage for today. The presentations and background materials in the book, thanks a lot, staff, for all the work that you did on that, and provides great impetus for collaboration between health literacy, public health, and the health system. And with the idea of better communication in simple, accessible, understandable, and actionable ways. And as I was listening today, I think that there are great opportunities for collaboration, to do research to determine the impact of the health literacy, public health messages that are coming out. Thank you. This was a great day.
Terrific. Ruth?
So some of my comments sort of just build on what everyone else, many others have said. I'm very struck by the need for public health literacy measures. And Lori, you said what gets measured gets managed. I would say what gets measured gets done. And you know, we've said that before, and I think it continues to be really an important thing. I think that's an important driver that we can take advantage of, and we heard that from education and others. So I think we really need to look at trying to think about what public health literacy
how we measure it, what it really looks like, and use that as a driver for moving forward. And I also have a bit of the next decade feeling. It was in 2005 when Julie Gasmarian and Jim Curran and Barbara DeBono and I put that piece out on public health literacy as an ethical imperative. And in that we talked about, and it was really as a follow-up to the IOM report that had just come out in 2004 that we're thinking about how to look 10 years later. But it was in that we talked about the need for public health literacy measures. And I think we're still there. So I think this is another opportunity, and it also is an opportunity that we have under the Affordable Care Act, where the landscape is certainly shifting daily. So I think this group has a great opportunity there, many options there of how we can use our networks and our thinking around it. And I think, be it public health, clinical health, physical health, mental health, there are ways that health literacy can help improve and be used as a primer for all of those. So thank you.
Good. Drew, do you have something from the internet?
Yes, I have Cindy Brock's comments. Cindy of AHRQ. Not being immersed in public health, Cindy had wondered whether health literacy and public health had a fundamental difference from health literacy in the healthcare sector. After today's presentations, Cindy came to the conclusion that these sectors have much more in common on how they address health literacy than differences. They both need to address workforce training issues. They both need to involve the communities they serve and the target audiences of their messages. They both could use models and tools to make their work easier. They both need to address the challenges of spread. It's quite heartening to see how the attributes of a health literate organization, which was developed with health care delivery organizations in mind, appeared to be relevant and helpful to those leading the way in public health.
Oh, thank you, Cindy. That's very helpful. We've got, before I go to you though, we're going to have time for the speakers and the members of the public to come to the microphone and make comments as well. So I'd like you to think about that. And if you are so inclined, begin to line up for me. Thank you so much. Patrick? I'm sorry, Andrew. I beg your pardon. Your microphone's not on.
Okay, there you go. Thank you very much, because I knew I was close enough to it. I really just needed my notes. Sorry. There's one thing that didn't come up today that is in the commission paper that I'm sort of duty-bound to take 30 seconds and highlight in terms of the potential opportunity health literacy can present in public health. There's a population in the United States that's responsible for, that's not the right word, that suffers from 19% of all HIV cases, 30% of all hepatitis C cases, and 15% of all hepatitis B cases. More than 30% of this population suffers from a mental health condition, and more than half have some form of addiction. This population in 2012 consisted of more than 10 million people. And that is the population of people who, for one reason or another, spend time in jails and prisons. There is an incredible opportunity to advance not only public health, but to prove the validity and utility of health literacy among those people. So for everybody here and those listening on the internet, I would encourage you, graduate students wondering where you're going to do your thesis and dissertation, there is a huge opportunity there. Yes, it has particular challenges, but it's not impossible to do. So I just wanted to quickly point that out. We set out with the commission paper not to criticize public health, but to perform a critical analysis to illustrate the opportunity that health literacy presents to improve public health at a lower cost. And the difference between criticizing and a critical analysis, I think, is important. And part of the reaction to the map is what brings this to mind. We did not set out deliberately, on purpose, to look for health literacy under a rock or in the weeds. We wanted to see where public health had decided that health literacy was important enough to highlight it so that when we called or emailed their front office person who took all input that you got to think about what happened is somebody got that message and they got up and they walked around and they asked whoever they're supposed to ask within the public health agency what the answer is. And for the ones who didn't reply, for whatever reason, after 3 attempts, they still could not come up with an answer. That doesn't mean that somewhere in the weeds, they weren't doing something that those of us who see health literacy in everything would say was health literacy. It means that they didn't recognize the individual role of that. And my personal advocacy position is that health literacy should not be under the weeds or in the weeds or under the rock. It should be highlighted as an important and critical part of the mission of public health. I'm very gratified to hear people seem to agree that it's a good idea to update the original IOM report. And so what do we need, to be blunt about it, is resources. So there are people here and listening around the world who I urge you to raise your hand and don't talk to me, talk to Lila, right? And say, let's do this, let's get it done. I think the time is now, and certainly it's possible. And just to quickly close, those who are interested in health literacy in a university environment, look at the Ohio State University College of Nursing. We're just on the very last stage of getting a new undergraduate degree in health and wellness innovation and health literacy, and experiencing how to take care of your own health are both central to that undergraduate degree. And they also have a university-wide health and wellness initiative called Buckeye Wellness that fits the model of what you were looking for. And so then just now, thank you to the planning group, right, and all the presenters and my co-authors on this. I want to just say, we did it.
Great, thank you. Right up there. Say your name and...
My name is Marie Fongwa from Azusa Pacific University School of Nursing. I really appreciate all the knowledge I've gathered here from the members of the roundtable. One thing that stood out for me was the connection between health literacy, cultural competence, and health disparities. They really hit home for me because I think the three are connected. In addition to placing health literacy in the domain of cultural competence, I think maybe one way to do it is to tell people that this was part of the three that go together, and it was forgotten instead of just sneaking it inside and they not really getting the understanding that it was a piece, it was an important piece that was not addressed in the first place. Sometimes I think when some people see the words health literacy, they think of ethnic minority groups, just like they do with cultural competence. And today, and maybe even before, we all have realized that even those who can read and write and understand, sometimes they cannot interpret the healthcare jargon. So health literacy is part of being cultural competent.
Thank you for that point. Actually, I was going to raise that myself if you hadn't, and I appreciate your doing that. Let's go right over here.
Yes, Champagne again. It's a fantastic conference. Please. Champagne Fanchan is my name.
Thank you.
And I think this conference is not only inspiring emotionally, but also stimulating intellectually. So I really appreciate that we have this.
Yeah, dangerous.
To some extent. I'm still on. Okay, great. Just to make it brief, I think we need to build our health literacy choir. We need to extend the choir to multiple sectors of the culture in our healthcare in U.S. and also in the whole world. And I have something to share about updating health literacy. And I think health literacy may need to be articulated and woven tangibly into the concept of cultural and linguistic competency. Ditto with the last person presented her idea. And knowledge translation should be looking at looking at everybody as learners. So not just healthcare provider translating knowledge we learn from clinical research, but also what does it mean, the health knowledge that's being received by the consumers, everyday person out there. And patient safety. There's so many things about patient safety that every one of us need to know. So patient safety-based health literacy curriculum in this area should also be articulated tangibly. And wellness. What a wonderful opportunity to talk about wellness, because I was sitting there thinking about all the wellness model that I know. I'm having a hard time now to really differentiate what are the nitty-gritty part of health literacy and the good practice of wellness, to be a well-informed consumer in healthcare arena and collaborating with healthcare providers to promote our own health. And also that we need to connect and collaborate with the stakeholders of all these concepts. In my opinion, it is okay. Health literacy is not a core curriculum in any educational system. However, if health literacy can be written in a spiderweb fashion, woven into every single one of those magnitude concepts, then we're winning. We don't have to be the core centerpiece, but we're everywhere. Thank you.
Thank you very much. Olivia?
Thank you. I would like to thank the Planning Committee as well as the Roundtable members and the IOM staff who came up with this idea to talk about public health and health literacy, because obviously from what we discussed, we need more of this discussion, more of the dialogue. And I was able to bring it to the American Public Health Association Education Board at our November meeting and convince them that this is a topic for their theme for next year. So in New Orleans next year, we're going to have the theme for all the education board sponsored sessions, and learning institutes are going to be focused on this topic, talking about education in cultural competency, health literacy, health disparities, to have a more detailed dialogue. So thank you for coming up with the idea.
Great, thank you. Don.
Well, first, thank you for letting me part of this. Is really a great opportunity. But one of the things, I did have an email from my staff and wanted to know how come we're a white state. We filled out the survey. So I just thought I'd pass that on. The second thing I wanted to mention is one thing when you're thinking about health departments, it's true in our state and it's, I think, true in a lot of health departments, the communications office, which could be a center for this kind of health literacy focus, they often function primarily just as a public relations function. And that's not a criticism, that's what they're asked to do. But I think that ideally they would be broader than that and have the staff that could help all of us that work in health departments in terms of our messaging and expertise. The other thing is, I think that in looking at health literacy, if you could include a public policy focus for things like gun control or other things that are politically charged. I mean, there's a thing, like in our state, we're concerned a little bit about fluoride right now because CDC is going to raise or reduce the amount of fluoride that in the guidelines that has to be included in water in the northern states anyway, because they found out that the southern states actually don't drink more water than we do, but some reason that means they lower it in the north in terms of the requirements, where before they thought we didn't drink as much water, so we had to have more fluoride or a higher concentration. So it's going to be reduced. But at the same time, there are advocacy groups within our state that are saying they're poisoning our bodies with fluoride, and have actually made inroads with a couple of legislators. So that's the kind of thing that, in terms of educating the public and being able to provide a message for different populations that are used to come from countries where the water isn't any good, and the government, they have reasons to believe the government is out to hurt them, and in a new environment, how do we help reframe that?
Great, thank you very much. Jennifer?
This is Jennifer Dillahay from Arkansas, and I guess my main take home is gratitude for today. I think this, having the opportunity to present what we've been doing in Arkansas has been very validating for the things that we've been doing, and I really, really appreciate that. I think at the core of all of this that we've been talking about, cultural competency and health literacy and so forth, is really this notion of equal opportunity for health and respect for all persons. And that I I hesitate to use this word in this context because it can be misinterpreted, but I think what we're talking about is loving the people that we care for. And if we can have the courage to do that in a way that pushes against those that would not want that, then I think that we can make progress. So thank you.
Thank you very much. So a lot of good observations on today, a lot of good presentations. My own kind of impressions are is that we've sort of barely scratched the surface of public health and health literacy. I think when I think about public health and the origins of the health literacy movement, as we heard from CC and others, it really started in a concern about communication one-to-one to patients and in healthcare delivery. Seems to be a lot of the emphasis. And the nature of public health is different. It really concerns itself with the health of populations in geographies. And I'm not so sure that we really grappled with that as much as we might have in our discussion, not because we didn't intend to, but because it's hard to, I think. I think Chloe Bird this morning, when she talked about the fact that an individual living in an area with relatively high health literacy benefits from the knowledge and ability of friends and neighbors, as opposed to those that live in areas of low health literacy, may actually not benefit, may have counterproductive, I think begins to get to the real essence of public health in terms of the fact that what happens in populations actually matters to individuals in those populations. And so therefore, it's not just interventions that affect the ability of individuals to act on their own behalf, but it actually concerns us to change the nature of those factors which create health in populations, local populations as well as state populations. And I think we sort of barely scratched the surface of that today. I think we could have explored that, a lot more. And I think this conversation today actually sets up us thinking a little bit more about that. I think, Andrew, you and your team, in terms of the paper that you put together, opened our eyes at least to look through another lens of the many lenses you could look at public health and see what a crisis it is in this country with respect to resources and skills. It was a sobering sort of look, at least from my perspective, in terms of the variety of responses or non-responses that you had. When we think about communication, you have to think about listening as well as the message you want to send. And if it's so hard to penetrate our own experts in those public health departments in these various localities, well, that's a real challenge and a problem for us. And then I think a number of commenters from the excellent examples we have from state public health and local public health that we had today really talked about the fact that if we wanted to take those attributes that have been developed in our previous conversations and apply them to public health organizations, you have to adapt them. And they're not perfect. And they don't really get to all the issues. And I really appreciated the number of comments that people made that tried to reflect upon that and strengthen that. And so it really begins to point out that there's a need to think about what the attributes of a public health department or a public health organization might be at a state, local, or federal level. And not just take and retrofit a set of attributes that might have been developed with other kinds of organizations in mind. So I think there's an opportunity there for thinking about that. And then when we got to the end, toward the end of the day, we started talking about training. There's a lot to be optimistic about in terms of some of the efforts, but there's also, quite frankly, a lot to be concerned about in terms of the opportunities, in terms of preparing the workforce going forward. And when we have such variation in definitions across our country in terms of public health departments, we don't even have a consistent view of concepts here. So we've got a big task here ahead of us, and I think we shouldn't look at it as being depressing, but we should begin look at that as set the table for some of the challenges that we need to be discussing in this roundtable, and that we need to be figuring out how to create conversation and motivation around addressing, because there is a set of challenges here that's quite significant in terms of expanding this important topic that we have in terms of good communication and improving health literacy. I especially appreciated the comments of CC today. Gives us a nice context for thinking about how far we've come, but also it sets out the fact that with leadership and courage and energy, how far we can go. And so I'd like to leave us with that thought as we begin to dissect this conversation and think about some of those challenges, is how far we can go and where we can get to. If there are other comments that people would like to make, we've still got a few minutes. Be happy to have them. If not, we may be at a point where I should join a number of others who have already thanked the staff under Lila Hernandez's leadership. Thank you to those that arranged for this facility, the internet, the webinar, the reminders. Terrific job. I'd like to thank all of you who've taken the time to join us today. I'd like to thank in particular the speakers and the guests who've taken time to prepare the information to stimulate our conversation. So let's thank those presenters. And as I always want to make sure I do, is I want to thank the Roundtable members and the sponsors of the Roundtable for putting your energy and attention and resources into creating this opportunity for dialogue around health literacy. So thank you all as well. So we stand. Now, are there any announcements I should be making? Terrific.
And is there going, and you said there will be slides for those of us who have
The
slides will be posted on the Roundtable website within a couple of days.
So the slides will be posted on the Roundtable website for those of you who are still tuned into the webinar.
Videos will take probably a couple of weeks.
And the videos will be posted eventually, probably in a couple of weeks, because it takes a little longer to do that. So at this point, we stand adjourned. Thank you very much.